Thank you very much, Chairperson. And my job is really to tell you whether it's the chicken or the egg first, and there really no clear answer from this. And I really don't have any relevant disclosures, but one important one is that I've never done a THR in my life. I probably have assisted maybe few. So if I have made some basic mistakes in my understanding of THR, so please forgive me, or maybe you can correct me at the end of the talk. But I really want to give this talk from the perspective of the spine surgeon as to what you should think about, because I don't think we are very well aware of this problem. And really what the problem is that the literature tells us that when you do THRs in patients with prior spinal fusions, there are poorer outcomes of these THRs, and the dislocation rates can be as high as 18%, which are as close to dislocation rates you see in revision THRs and megaprosthesis surgeries. And this leads to infections and revision surgeries and poorer outcomes overall. Moreover, when you see patients with multi-level spinal fusions and THR, the outcomes are even worse than patients who have 1 or 2 levels of lumbar spine fusion. What happens when you reverse the sequence means basically you do a spinal fusion in a patient who already has a THR. Same story again, higher dislocation rates, revision rates, and complications. So it's like kind of a no win-win situation here. So really one has to understand what will be the order of operation in a patient who has a hip spine syndrome. You have an elderly person who have both hip and spine problem. What would you do first? And I think as this kind of an issue in India is not so common because we don't see as many primary hip arthritis patients who at the same time elderly patients have a spinal issue which requires surgery. So this is not a very common situation, at least in our country, as far as I have gathered from what I did research on. So really you're looking at it from a hip surgeon's perspective who sees a patient with hip arthritis, but now this patient already has a hip fusion prior, or from a spine surgeon's perspective, you have a patient who has a hip arthroplasty, but now the patient needs a spinal fusion for a degenerative problem. And one has to understand why this is really an issue. When you look at a human being from standing to sitting position, we really imagine that the movement is happening only at the spine, but this is far from the truth actually. When a person sits down, there are two places where movement occurs. One is at the hip joint and the other is happening at the lumbosacral junction. So you imagine there are two places where the gears are located where our hip bends. Look at this animation. When the patient goes from standing to sitting position, the pelvis is retroverting, it's going backwards, and that movement is happening at the lumbosacral junction, and you can see the lumbar lordosis is also reducing. So this is what is happening in a normal person who has a flexible lumbar spine. But if you have a stiff lumbar spine, either because of degeneration or because of surgery, what happens is when the patient goes in a sitting position, the pelvis remains in that position because the lumbosacral junction is not moving, the lumbar lordosis is not moving, so more stresses are taken by that hip joint. Here is an X-ray depiction from standing to sitting position. You can see in a normal spine, the anteversion of the acetabulum in sitting position is going to change because the pelvis is retroverting, and as the pelvis rotates backwards, the anteversion of the acetabulum is actually increasing. But what happens if you have a stiff lumbar spine? In a stiff lumbar spine, the anteversion doesn't change and it causes impingement of the cup to the acetabulum in the anterior position, and the ball can dislocate backwards or posteriorly. So this version has kind of an inverse relationship. In standing position, the pelvis is anteverted with an acetabulum relatively retroverted, and that's exactly the opposite in sitting position. So this is a diagrammatic representation. We all know pelvic incidence, at least the spine guys know about pelvic incidence. Pelvic incidence is just the morphometry of the pelvis. It doesn't really change. So when you go from a standing to sitting position, what is changing is the sacral slope and the pelvic tilt. Along with it, the acetabulum is also changing its position. It is going more anteverted. So if you have a rigid balanced spine, so the spine surgeon has fixed the lumbar spine rigidly lumbosacral, but it is a balanced spine. He has not fixed it with a flat back deformity. When the patient goes in a sitting position, the acetabulum is not going to change its version. It's going to remain anteverted. You will have anterior impingement, and you have a tendency for the the ball to dislocate posteriorly. Whereas if you have a rigid, unbalanced spine, that means the spine surgeon has fixed the lumbar spine as a flat back syndrome, then what happens in the standing position is, for compensation, the pelvis is going to be retroverted. It's going to roll back so that the patient can stand forward in a vertical position. But in a rolled back position, in the standing position, what will happen is that there is limited extension to the hip prosthesis, and it's going to impinge posteriorly and dislocate anteriorly. So then we come to the question, what you should do first. So this is a Medicare database. A short-term follow-up at least shows that if you do THR first, then your dislocation rates are relatively smaller, and 2-year data is also similar. THR first are kind of better outcomes, but this study, even though it's a large Medicare database study, has a lot of selection bias and some problems with the methodology. So I'm not really sure whether you should really believe this data in the first place, but there probably is some theoretical background behind this, maybe because if you do a THR first, you are giving an opportunity for the components to osseointegrate, for the hip capsule to get scarred in, for the surrounding muscle to get rehabilitated. And maybe in that kind of a situation, if you do a hip spinal fusion at a later date, that hip can withstand those minor biomechanical changes better than if you have a patient with a stiff lumbar spine and then you are doing a THR where you're not really giving it an opportunity to kind of settle down. So this also means that probably the interval matters. And this, again, a Medicare database study shows that if you have a gap between the THR and lumbar fusion, then the dislocation rates are lower. But really a patient who has a hip spine, can I take one minute extra? So if you have a patient with a hip spine problem both together, you are really not going to tell the patient that, okay, I'm going to do your THR first and you'll have to wait for 5 years to get your lumbar spine done. That's not really a practical solution for a patient who has both problems. So in conclusion, I don't think this is a big problem, at least in India. I'm not really sure, in spite of scavenging the Hinduja guys who do arthroplasty, I couldn't find a single case which was representative of this problem. So maybe I'm wrong, maybe in audience people have some cases relevant to this problem. But from a spine surgeon's perspective, really, I think we as spine surgeons should be aware that lumbar spine fusions might cause problem in a patient who already has a previous THR. And maybe there is if you have a patient with a recent THR, maybe there is some rationale to delay your lumbar spine fusion if you have kind of the opportunity to do so. Thank you very much.